Hello and welcome to Sewa Tutorials. Today we'll be talking about glaucoma, so let's dive straight in. So our objectives with this lesson today will be to define what glaucoma is, its classifications, the etiology, the risk factors and how we diagnose glaucoma. We'll also be discussing how we manage and treat glaucoma, and also, just for context, to remember that these illnesses affect real people. Just a few examples of some notable figures who were diagnosed with glaucoma. So, what is glaucoma? Glaucoma is classically defined as a group of eye diseases characterized by increased intraocular pressure or pressure within the eye, which causes damage to the optic nerve. This is the nerve responsible for visual acuity. Whilst this definition is true, there is also a much rarer form of glaucoma known as normotensive glaucoma, where the intraocular pressure is either normal or just mildly elevated, but still displays the same changes to the optic nerve as we see in hypertensive glaucoma. This particular type of glaucoma is quite difficult to treat because a lot of the treatment we will discuss later focuses on lowering intraocular pressure to prevent damage to the optic nerve. So, of course, the treatment for normotensive glaucoma will be a little bit different, but for now, let's stick to this definition. So, glaucoma can be categorized overall in one of two ways. This is primary or secondary. In most cases, when we talk about glaucoma, we're talking about primary glaucoma, which includes closed angle, open angle, and congenital glaucoma. Congenital tends to occur due to structural abnormalities within the eye that occur during intrauterine development, whereas the other two describes the angle of the anterior compartment of the eye, which we will explain in the following slide. Secondary glaucoma typically refers to increases in intraocular pressure caused by infection, surgery, trauma, cataracts, or neoplasms. So here we will mainly be focusing on closed and open angle glaucoma. In order to understand how primary closed angle glaucoma works and angle closure glaucoma in general, let's take a quick look at the anatomy of the eye. So the eye is split into three chambers: the anterior chamber, the posterior chamber, and the vitreous chamber. The anterior chamber is limited anteriorly by the cornea and posteriorly by the iris. So as you can see here, this is the cornea, this is the iris, and this is the anterior chamber in between. The posterior chamber is the smaller compartment between the lens and the iris. So that's this little section here. This is the posterior chamber. The posterior-most part of the eye, which is not labeled here, is the vitreous chamber, containing the gelatinous vitreous humor. The anterior and posterior chambers of the anterior compartment of the eye are nourished by a fluid called aqueous humor, which is secreted by the ciliary bodies of the iris. So that's this little section here. These are the ciliary bodies. As you can see, these are the ciliary bodies. This fluid passes over the lens and enters the anterior chamber through the pupil. From here, the fluid is then filtered out of the anterior chamber through the canals of Schlemm. So these here are the canals of Schlemm. This is the canals of Schlemm. From here, the fluid re-enters circulation and the cycle is constantly repeated to maintain hydration and nourishment of the eye. And this is maintained at an optimal pressure of about 10 to 21 millimeters of mercury. In primary angle closure glaucoma, the space through which the aqueous humor passes in order to reach the anterior chamber becomes blocked, and the aqueous humor cannot leave the posterior chamber, or it cannot filter out of the anterior chamber.
This causes the fluid to back up, and this leads to an increase in intraocular pressure. As the pressure increases, it compromises the retina and the optic nerve at the back of the eye, which affects visual acuity. Rapidly occurring primary closed-angle glaucoma can also be referred to as acute. Whilst chronic forms do exist, in the acute phase, symptoms develop very rapidly, presenting with blurred vision, hyperemia. So as you can see in this picture here, the patient's normally white sclera is very red. Patients can also experience tearing and edematous cornea. So in the same picture, you can see that the cornea looks very swollen, very full. So this is what we mean by edematous corneas. Patients can also experience headaches, globe pain, nausea, and halos around lights. So this is what we mean by halos around lights. Essentially, it's like a glare on a camera. So this is what a patient with glaucoma can see, which is much worse at night. So how does someone develop glaucoma? As it is primary, the direct cause for this type of glaucoma is either idiopathic or cryptogenic, meaning we don't know, or it's difficult to find the reason for the cause. What we do know is that there are risk factors which can contribute to the development of primary closed-angle glaucoma. This includes being of Asian descent, having diabetic retinopathy, having severe malignant hyperopia or myopia, and being of older age. So how do we diagnose primary closed-angle glaucoma? The diagnostic steps for all types of glaucoma and pretty much all ophthalmic disorders are essentially identical, starting with inspection of the eye, where we can see all the gross overt changes of glaucoma, followed by a visual acuity test. All types of glaucoma require a visual acuity test, which will be markedly reduced. In acute settings, this can be quite difficult to assess, as opening of the eye by the patient may be limited by pain. We can also conduct a perimetry test, which assesses the peripheral vision, which can also be markedly reduced in glaucoma. So this is an example of a perimetry exam of a patient with acute glaucoma. So the areas marked in black are where the patient cannot see or they cannot perceive these fields. So here the patient has complete anopsia in the right eye, and a large proportion of the peripheral vision in the left eye is also reduced. We can also inspect the fundus of the eye with an ophthalmoscope, which will display cupping and blanching of the optic disc. We can measure the pressure of the eye with tonometry, which in acute settings will always be greater than 21 millimeters of mercury. Even in the most severe of cases, pressure can be as high as 40 millimeters of mercury. We can use gonioscopy to measure the angle of the anterior chamber. So the normal angle is about 35 to 36 degrees. So in primary closed-angle glaucoma, this will also be reduced. Optical coherence tomography also allows us to measure the AC angle in 2D. And finally, we can test the pupillary light reflex, which will also be reduced if the optic nerve has been severely compromised. Let's move on to treatment of closed-angle glaucoma. So primary closed-angle glaucoma is a medical emergency. If patients are not treated promptly, it can lead to permanent blindness in the affected eye, and it can also affect the contralateral eye as well. Management can be medical or surgical, but in acute settings, it is often a combination of the two. Mainstays of medical management include timolol and pilocarpine, which reduce the formation of aqueous humor and induces meiosis in order to open the AC angle respectively. Bromidine, an alpha-2 receptor agonist, and acetazolamide can also be used as second-line agents. Surgical interventions can also be adopted in conjunction to medication. So filtration and laser surgeries can be used to punch a hole in the iris, known as iridotomy. This provides an alternative route for the aqueous humor to drain from the eye. For chronic angle closure glaucoma, or to prevent recurrent episodes where the cause is unknown, drainage devices can be fitted into the eye as long-term management after the correction of the acute episode, of course. The device can be fitted underneath the eyelid with a drainage tube from the anterior chamber. Now let's move on to open angle glaucoma. So as we mentioned, this is glaucomatous changes occurring in the eye without compromise to the AC angle. Pressure can be increased or normal. And as with primary closed angle glaucoma, the direct reason why pressure increases is unknown in the majority of cases. However, studies show that there may be an anomaly at specific points in the chain of production of aqueous humor or in its filtration. So either there's a defect in the ciliary bodies causing an overproduction of aqueous humor, or there's a defect within or just before the trabecular meshwork, or the canals of Schlemm, causing an underfiltration of aqueous humor, or it can be a combination of both of these mechanisms. As with primary closed angle glaucoma, open angle is also associated with a number of risk factors. There are a few overlaps between the two conditions, for example, being of older age, having myopia, and diabetic retinopathy. However, primary open angle glaucoma tends to affect those of African descent rather than of Asian. Patients with a family history of glaucoma, systemic hypertension, and patients with thin corneas also tend to be affected as well. This type of glaucoma is normally chronic and is rarely acute. The onset is insidious, initially asymptomatic with a gradual decline in vision that most patients would assume is age-related rather than pathologic. Patients may also experience globe pain and hyperemia, although both of these symptoms may not be present at all. So patients wouldn't typically notice the changes or the symptoms of glaucoma until the advanced stages of vision loss are already present. So we use a lot of the same diagnostic tools for open angle as we did for closed angle. So again, we are checking visual acuity and we are checking perimetry, which will both be reduced or severely compromised. But like we said, in the early stages of open angle glaucoma, visual acuity can actually be normal as well. There won't be any demonstrable changes in the AC angle, and pressure on tonometry may or may not be normal as well. There will be insidious changes in the nerve at the back of the eye with evidence of cupping and damage to the nerve on fundoscopy. So this is a brilliant example of the cupping and blanching you might see in a patient with glaucoma. So for context, the image on the left is what a normal optic disc looks like, and the image on the right is a patient with severe advanced stage glaucoma. Lastly, we can check the pupillary light reflex, which will also be markedly reduced. As the process is chronic, there isn't really a cure to the condition, and it is instead managed over time. There are a myriad of medications that we use to control the pressure, and most of these medications are very effective in long-term management, only limited by a few side effects like arthralgia and bronchospasms. Surgery is indicated for patients who do not respond well to medical management and uses lasers to destroy part of the ciliary body in order to reduce the amount of aqueous humor that is produced. Notable side effects include a transient intraoperative rise in intraocular pressure, which can worsen glaucoma symptoms. This is, of course, remedied by regular intraoperative monitoring of pressure and treating it accordingly. Lastly, filtration devices can also be used again for long-term management. Lastly, let's quickly go over secondary glaucoma. So secondary glaucoma is way more straightforward than primary glaucoma because the treatment is always to correct the underlying issue. For example, if glaucoma is secondary to phacolytic or phacomorphic cataracts, for example, correction of the cataracts is normally sufficient to reverse the glaucoma. Other causes of secondary glaucoma include uveitic, caused by direct inflammation to the uvea, neovascular, caused where new blood vessels grow over the trabecular meshwork. This is present in diabetic retinopathy, age-related macular degeneration, or other neovascular conditions. Glaucoma secondary to intraocular tumors, of course, this is self-explanatory. And lastly, traumatic glaucoma. So this is, again, a brilliant example of a traumatic glaucoma where there is bleeding in the anterior chamber or hyphema, and this is causing the glaucoma in this patient. So just to remind ourselves during our studies that these conditions do affect real people, here's just a few examples of some notable figures who were diagnosed with glaucoma. So Whoopi Goldberg revealed in 2014 that she was living with chronic angle closure glaucoma. And the famous Irish singer Bono was diagnosed with glaucoma a few decades ago as well, and is well known for wearing his tinted glasses, which he wears since his diagnosis. So I hope you enjoyed this video on glaucoma. Today we learned the definition of glaucoma, the mechanism behind it, the risk factors, the diagnostic techniques, and the treatment. As always, the link to our free revision flashcards will also be in the description, along with all the references used in this video. If you enjoyed this video and would like to see more detailed and in-depth lessons and explanations like this, please don't forget to comment, let me know what you enjoyed, like this video, and subscribe. All the best and happy revising.